Okay, Bismillahirrahmanirrahim. Let's start with 401. An 11-year-old girl visited Pete's OPD with pallor and jaundice. There is no history of fever or bleeding. Physical examination revealed pallor, bile jaundice, and no visceromegaly. CBC revealed TLC of 7.5, hemoglobin 8.3, platelets 50, MCV is 95, MCH 31. Okay, here we have TLC is normal, hemoglobin is low, platelets are low. MCV is 95, MCH 31. Bone marrow examination revealed erythroid hyperplasia and increased megakaryocytes with young blue form. So these increased megakaryocytes, young blue form, show that these are immature megakaryocytes. When a lot of megakaryocytes are produced, then we can see the mature forms in the bone marrow. However, no abnormal lymphoid infiltrate is seen. What is the most likely diagnosis in this case? So in this case, the most likely she has low hemoglobin, low platelets. So, and the bone marrow, we have erythroid hyperplasia, and we also have increased megakaryocytes, which are compensating for the low hemoglobin and low platelets. So in this case, the answer will be Evans syndrome. Evans syndrome includes autoimmune hemolytic anemia, and it includes immune thrombocytopenia. Okay, this autoimmune hemolytic anemia and immune thrombocytopenia together is called Evans syndrome. Okay, next is a lab technician consults registrar hematology. That CBC card of a 45-year-old male patient shows a MCV of 145. MCV is 145. MCH 52, and hemoglobin 8.1. The clinical history of the patient reveals that he has complete a bluish discoloration of skin of the hands in winters. So peripheral cyanosis is there. But, what is the most appropriate investigation in this patient? So in this patient, you can see like the hemoglobin and the MCV is quite prolonged. MCH is 52. So this is not the normal count. So it occurs whenever there is agglutination. We can see on the peripheral blood smear there is agglutination. So we will see that MCV and MCH are falsely increased, and hemoglobin is less. It is 8.1. So, and this occurs in winter, so it is associated with cold agglutinin disease. In this case, what is the appropriate investigation? If we see like if we see this type of hemoglobin and MCV, MCH is raised, and this is a clinical when we ask the patient, he will say that like he have like a winter induced acrocyanosis. So what will we investigate? We just think of it as an autoimmune hemolytic anemia, cold type, like which is called as cold autoimmune agglutinin disease. We will do a Coombs test. The Coombs test will come positive. Okay, it will be positive for C3D and not for IgG. Okay, next is a 10 months old boy is referred to hematology clinic for evaluation of easy bruisability and prolonged bleeding after minor trauma. His maternal uncles also has similar complaints. Maternal uncles, okay, boy and maternal uncles. CBC revealed hypochromic microcytic anemia, normal TLC, and normal platelet count. Coagulation screen revealed bleeding time of 2 minutes. So bleeding time is 2 minutes, and coagulation is PT is normal, APTT is prolonged. His prolonged APTT was corrected after mixing with the aged serum. Okay, so aged serum, last time we discussed, we have aged serum, aged plasma, and adsorbed plasma. So this is corrected by aged serum. However, APTT remains prolonged after mixing with the adsorbed plasma. So adsorbed plasma contains what? Adsorbed plasma corrects what? It corrects factor 5, factor 8, and it also corrects fibrinogen deficiency, and it corrects 11 and 12 both. So it is not corrected by adsorbed plasma, so it is not factor 5 and factor 8, and it is also not it is not factor 11, factor 12. So it is corrected by aged serum. So which, but first of all, you can see like it is a hemophilia case, because patient, it is a boy, okay, and his maternal uncles also have these complaints. So we suspect like an APTT is prolonged, an isolated APTT is prolonged. What we have hemophilia A, hemophilia B, hemophilia C, factor 8, factor 9, factor 11, and 12, factor 12. So in factor 12, I said that there is no bleeding, that those patients with factor 12 have prolonged APTT, and they don't bleed. So what we are left with, factor 8, 9, and 10. 8 and 9 have this type of scenario, like patient has because both are X-linked, and the 11 is autosomal recessive, and in factor 11 deficiency patient bleed after trauma, and but that bleed is a mild to moderate bleed, and it usually occurs like if a patient has a tonsillectomy, or if patient have some uterine surgeries where there is high fibrinolytic activity, so those patients bleed, and in that case antifibrinolytics can help. Okay, but this type of scenario is typical of hemophilia A and hemophilia B. Now, if it was corrected with adsorbed plasma, so adsorbed plasma contain what? It contains factor 5 and 8. So it is not corrected with adsorbed plasma. So it is not factor 8. And it is corrected with aged serum. Aged serum has what? It has vitamin K dependent factors 2, 7, 9, 10. So it is corrected with aged serum and not corrected with adsorbed plasma. So it is factor 9 deficiency. This is factor 9 deficiency. Okay, now just revise it. When APTT is prolonged and it is corrected by aged serum, okay, but not corrected by adsorbed plasma, so it is factor 9 deficiency. And when we do the reverse, APTT is prolonged and it is corrected by adsorbed plasma, so it could be factor 8 deficiency. Just revise the previous video. Just see the previous video. I had explained this aged adsorbed and adsorbed plasma and aged serum and aged plasma, because you have to memorize it the way I told you. If you memorize it, I think so most of your MCQs which are based on this, which looks horrible in first sight, but if you have learned these concepts, so you can easily solve them. Okay. Next is 404. A 1-year-old boy presented with petechiae, epistaxis, and right elbow swelling. His mother also gave the history of umbilical stump bleeding at the time of birth. So, this is a very important thing. Like a 1-year boy, still he has petechiae, epistaxis, and elbow swelling, maybe some bleed. And her mother says that he had umbilical stump bleed at his birth. His coagulation profile, PTA, PTT both are prolonged. Okay, TT is also prolonged, and the bleeding time is also prolonged. So, what is the most likely diagnosis? So whenever there is a scenario which tells a small baby, and they tells us about umbilical stump bleeding at the time of birth, so just consider factor 1 deficiency or factor 13 deficiency. In factor 13 everything will be normal. So but in a factor 1 fibrinogen deficiency, as it is in a common pathway, so PT and APTT will both be prolonged. Thrombin time is also prolonged. Okay, so this scenario typically tells us that it is a fibrinogen deficiency. Then we have to do fibrinogen assay, clause assay to see the activity, fibrinogen antigenic assay to see the antigen levels, like it is afibrinogenemia or hypo, or it is dysfibrinogenemia. So that is something else. We have to go after first we have to suspect that it is a case of fibrinogen deficiency, as PT, APTT, TT all are prolonged, bleeding time prolonged. Because why bleeding time is prolonged? Because like we said, like when there is a platelet aggregation, GP between two platelets, we have GP 2B3A receptors on the platelets, and in that when in that thing fibrinogen is used. So fibrinogen is important for aggregation of platelets. So when there is no fibrinogen, there is problem in aggregation and bleeding time will be prolonged. So this is the reason behind that. Okay, next is 405. A 35 years old female presented with 4-week history of high grade fever, shortness of breath, and gum bleed. Okay, so her CBC showed TLC of 23,000, hemoglobin is low 7.3, platelet is low, and TLC is high. Flow cytometry from bone marrow sample shows 65% blast. So it means the TLC count is high because of the blasts, which are positive for CD13, 33, MPO, HLADR, CD34. Okay, so by now you should know that these all are the myeloid. It is these markers are for myeloid lineage 13, 33, HLA-DR4, CD34 is a marker for the blast or the immature cells, and MPO is positive. It means it is from M1, M2, M3, M4. Okay. Okay. What is your most likely diagnosis? So the most likely diagnosis is here: acute myeloid leukemia with maturation. Okay. So MPO is positive. So there is some type of maturity in these cells. Acute myeloid leukemia with maturation. Okay, next is a 28 years old male presented with abdominal pain. His CP shows pancytopenia. Okay, so 28 years old boy came with abdominal pain. So she has pancytopenia. Bone marrow is absent on pearl stain, but is the most specific test to diagnose the underlying condition. Okay, so I told you before, when it is a case of PNH, paroxysmal nocturnal hemoglobinuria. In that case patient usually have pancytopenia, and he presents with abdominal pain because of thrombosis. Okay, the iron stores will be absent, and if we when we do the bone marrow, there is erythroid hyperplasia. Okay, so what is the most specific test to diagnose a PNH case? So that test is a flow cytometry using a reagent flare based assay. Okay, so we will, for what we do, we have to do for CD55 and CD59, which will be absent in case of PNH. Okay, so just revise it. In PNH, you will see a triad of pancytopenia, absent bone marrow, iron, and intravascular hemolysis, and there is also you can see, we will see the thrombosis at unusual sites. So the option here is E. Next is 407. A 26 years old female is referred to hematology clinic for workup of low hemoglobin level. CBC revealed hemoglobin of 10. It is low. MCV is low. MCH is low. TLC is 10. Normal platelet is normal. Okay, so something here, these they are low. So the patient has anemia. Her ferritin level was 95. Okay, ferritin is normal. Capillary zone electrophoresis shows hemoglobin of 88. HB, it is HB A2 is 2.1 and HbF is 9.9. What is the most likely diagnosis? Okay, so this patient has microcytic hypochromic anemia. Okay, if it has a hemoglobin A2 raised more than 3.5, so it could be a case of beta thalassemia trait. Okay, from here, but in but here when HbF is this is normal and HbF is 9.9, or like it can raise up to 15 to 20 also percent. So what is the diagnosis in this case? It is delta beta thalassemia. And delta beta thalassemia, we have discussed before, it could be like 15% HbF also. And the other thing is it is heterozygous delta beta thalassemia, because in homozygous delta beta thalassemia, patient just have HbF. There will be no HbA, no HbA2, or very low, very low. Okay, so the patient just have HbF of around 98% or more than that. Okay, so this is a delta beta thalassemia trait. A 21 years old soldier develops episodic high grade fever with rigors and chills. His CBC showed TLC of 10, platelets 175, hemoglobin 9.5. MCV is 99 and MCH 31. Reticulocyte count is 3.9. It is increased. It's indirect bilirubin raised, LDH raised, which are the markers for hemolysis. So they are raised. What is the appropriate choice of investigation in this patient? Okay, so this is a case of hemolytic anemia. Okay, so what which type of investigation we should do? So hemoglobin electrophoresis is not needed because it is not for hemolysis. Serum ferritin, serum creatinine, bone marrow examination, yeah, screening. So we will do G6PD deficiency screening because he has episodic high grade fever. When he had fever and he had hemolysis at that time, so we should suspect a case of G6PD, and we should do a G6PD deficiency screening test. 409. A 3 years old biological presented in ER with complaints of severe pain in both feet for the past 3 hours. Okay, so she has it like when they say biological, it looks like a case of sickle cell, or and just you have to G6PD. So just look in that, just think about that. Then she say like severe pain in hands and foot, so hand foot syndrome same, and she has fever and cough for the past 2 days. So it can be a sickle cell crisis. She has pale spleen is 2 centimeter below the costal margin. HB is 6.2, platelets normal, WBC count is 16, neutrophilia may be due to infection, MCV is 89, MC is 30, and reticulocyte count is 8.9. Here is the clue. It shows like, and hemoglobin is low, so it is a case of hemolytic anemia, and this shows that it is a sickle cell disease. Which of the following reagents which we used for diagnosing this sickle cell disease is sodium metabisulfite, because sodium metabisulfite causes deoxygenating. It is a deoxygenating reagent for sickle cell test. Okay, so that's why we use it in vitro to see the cells, sickling of the cells. Okay, next is a 65 years old man diagnosed as a case of hypertension for last 3 years, presented with sudden onset of pain and weakness in the right half of the body. He has history of headache on and off for the last 6 months. Okay, so he has hypertension, headache. Okay, sudden onset of pain and weakness in right half of the body. He is a non-smoker, and on examination he has plethoric face. His CBC, this is clue. Okay, his CBC showed TLC of 12, hemoglobin 20, hemoglobin is raised, platelet counts are 430. The patient is hospitalized and given antiplatelet therapy. Which of the following should you order next? So it looks like he has plethora, hypertension, headache. Okay, so these all, and especially hemoglobin is raised. We don't know about hematocrit here, so hemoglobin is 20, so it looks like a case of polycythemia. Okay, and what we have to do to just see if it is a polycythemia rubra vera, we will do PCR for JAK2 V617F mutation. Okay, if this mutation is negative, we will also do JAK2 exon 12 mutation. Okay, so because in 97% of cases of polycythemia rubra vera, JAK2 mutation should be positive. Okay. A lab technician consults you regarding the recommended correction tube for the CVS chorionic villus sampling for prenatal diagnosis for testing of thalassemia. Which of the following will you recommend? Normal saline, formalin, distilled water, and heparin. So we will say normal saline. CVS transport. It is a CVS transport medium. It is kept in normal saline to preserve the DNA. Okay. So first is correct. Then a patient of Burkitt's lymphoma underwent tumor lysis syndrome and TLC count is so high. Okay, the patient can go into tumor lysis syndrome. Okay, the serum sample will show what when there is lysis of the cells, whatever is inside the cell will come out. So there will be increased potassium, increased phosphate. Okay, increased uric acid, and there is decreased calcium, because when phosphate comes out, the calcium will just bind with phosphate, so calcium level will be reduced. So this option is correct: increased uric acid, increased potassium, and decreased calcium levels. Next is a 40 years old female with backache. ESR is 80. Okay, ESR is quite raised. CBC shows rulo formation. Bone marrow shows 8% plasma cells, and SPEP serum protein electrophoresis show homogeneous paraprotein band with 28 gram per liter serum levels. So what is the diagnosis? So it's just a typical case of myeloma. Okay, plasma cell dyscrasias, but you have to see like is it MGUS, it is multiple myeloma, it is smoldering myeloma, or what. So here it is, what is the value here? Bone marrow cells are less than 10%. Okay, and SPEP shows less than 30% gram per liter. So when it is less than 10 and less than SPEP is less than 28, so it is a case of MGUS. Okay, M band less than 10 and bone marrow cells less than 10, and there is no crab, no and organ damage. Okay, so there is patient with, there will be no anemia, no lytic lesions, there will be no renal failure, and there will be no hypercalcemia, because whenever the lytic lesions, the calcium will be high, so we will have hypercalcemia. So when there are no end organ damage and these are less than 10 and less than 30, so we will say it is a case of MGUS. In smoldering myeloma, it is more than 30, plasma cells are more than 10, but there are still no crab symptoms, there will be no end organ damage. Okay, so we will call it smoldering, like it will smold into myeloma. Okay, smoldering myeloma. Then is multiple myeloma, or we have to call it symptomatic myeloma. In that case, you will see that M band is more than 30, plasma cells are more than 10, and there are features of end organ damage. Okay, so this is very important. When end organ damage when crab is present, so it is a case of multiple myeloma. In case of plasma cell dyscrasias, we have to do bone marrow examination first, and we have to do bone marrow examination, SPEP, serum protein electrophoresis, and immunofixation. Serum SPEP is to quantify the M band, and the immunofixation is uh, uh, to see like which type of band it is IgG or it is IgM. So we have to we know this by immunofixation. Okay, so we have to do the immunofixation if SPEP comes positive. Then we do UPEP and immunofixation for Benz Jones protein and light chain restriction. So these are the tests which we do for multiple myeloma. Okay, or plasma cell dyscrasias. Next is 414. A 45 years old male is having pancytopenia without any organomegaly. Okay, iron is a pancytopenia without any organomegaly, because if this says that is a splenomegaly is there, so we will say yes, there will be some sequestration of the cells in the spleen, and that's why we are getting pancytopenia or cytopenias in the peripheral blood. When they say there is no organomegaly, it means like there is no sequestration there. We have to say some other cause. Okay, so iron is absent on bone marrow exam. Urine for hemosiderin is positive. What will be the diagnostic test? So again, it is a pancytopenia here. Bone marrow absent. Iron is absent in bone marrow, and hemosiderin is positive. So hemosiderin comes positive in case of PNH. Okay, what will be the diagnostic test? So the diagnostic test is again flow cytometry, fluorescence areolizing test. Okay, we will do this to see CD52 and 55. Okay, pancytopenia and positive urine hemosiderin points to PNH. Okay, so many questions we have seen came from the PNH, so you should revise PNH before your exam. Okay, so it's an important topic. Next is a patient is having fever, gum hypertrophy, and hepatosplenomegaly. On CBC, TLC is 35, raised HB is 7, platelets are 20. Okay, so both bicytopenia, bone marrow shows whenever there is bicytopenia and TLC is raised, just think of some leukemias or something like that. Think of the blast cells. Bone marrow shows 85% blast cells having low NC ratio, prominent nucleoli, and abundant cytoplasm with no aurors and granules seen. So these are the it is the morphology of the blast, and in the they are saying there is abundant cytoplasm with no aurors. If there were aurors, we just go into acute myeloid leukemia. Okay, that acute myeloid leukemia, it could be M2, M3, M4. Okay, but most likely diagnosis here is it is as they are saying this is gum hypertrophy, so it more points more towards the M4 or M5. So here it is M4, M5, it is here. Okay, acute monoblastic leukemia is M5. So whenever there is gum hypertrophy, it is pointing towards the acute monoblastic leukemia. And acute promyelocytic leukemia, we will see promyelocytes in the blood. Okay, next question is, patient is having abdominal lymphadenopathy. Histopathology shows lymphoid cells with abundant vacuolation. Okay, whenever there is lymphoid cells with abundant vacuolation, thinks of Burkitt's lymphoma. IHC is CD10 positive. Okay, CD5 negative, CD23 negative, BCL6 negative, and TDT negative. So these markers are absent. Which translocation is most likely to occur? Okay, so this is a case of Burkitt's lymphoma, and in Burkitt's lymphoma, where what we will see, translocation 821. Translocation 821, MYC gene, okay, which activates MYC oncogene. So the option A is correct here. Okay. Next is regarding vitamin B12 metabolism. Which one is correct? Transcobalamin 2 transfers B12 to bone marrow. Transcobalamin 1 transfers B12 to bone marrow, or intrinsic factor delivers B12 to jejunum. No, it delivers to the ileum. So top one is correct. Transcobalamin 2, TC2 transfers B12 to the bone marrow. Next question is, a 4 years old boy with bleeding, child with bleeding diathesis. Bleeding time was 4 minutes. Okay, he came with bleeding. The bleeding time is normal. Okay, if from here we know that there is no platelet disorder or platelet defect. PT is 37, APTT is prolonged. Both are prolonged, so it means like there is a defect of common pathway defect. Okay, most likely diagnosis is, and what was in the common pathway? 5, 10, 2, and 1. So which one is here? So it is 8, 1. Okay, factor 10 is here. 419, a 55 years old patient was transfused RCC. After second unit, he started having shortness of breath and chest discomfort. He is having TACO, transfusion associated circulatory overload. He has trolley, okay, which is transfusion related acute lung injury, or he has acute hemolytic transfusion reaction. Okay, so this scenario is little bit incomplete for me, because this could be a case of TACO. If a patient has because this is old, 55 years old patient. He may be hypertensive, he have maybe have cardiac compromise or renal issues, and with the second unit he started, it will be it is circulatory overload, so he can go to, he have shortness of breath and chest discomfort, so it can be a case of taco. And it can be a case of trolley second hit. When there is a second hit, like the second unit is given, patient will develop acute lung injury, and because of the acute lung injury, patient will have hypoxia and bilateral infiltrates. So that can be a case of trolley. And acute hemolytic transfusion reaction, in that case also patient can have dyspnea. Okay, so I think so in the exam we will get a little bit more like information, then we can decide easily. Okay, so just to revise the concept here, so the concept is like whenever there is after transfusion, patient presents with shortness of breath, dyspnea. So the DDs will be trolley versus TACO, acute hemolytic transfusion reaction, or just transfusion associated dyspnea. Okay, the timing here is in trolley and TACO will both occurs like less than 6 hours. Acute hemolytic transfusion reaction is immediate, and transfusion associated dyspnea is like just transfusion related dyspnea in less than 24 hours. The patient can present with that, and this don't have any severe complications. Okay, so let's go for trolley. Trolley is a sudden dyspnea. Okay, patient will develop sudden I just want to explain it in few words to you, but I have written it all so that you can, when you have to revise it, you just read this concept and no need to open books for that. So in trolley, less than 6 hours post transfusion, patient will present with severe hypoxia, severe dyspnea. Okay, which occurs why? Because there is some injury to the lungs. And what is the mechanism? There is in the donor cells we have anti-HLA and anti-HNA, anti-neutrophilic antibodies, or there is some two hit phenomena. So it is important for heme residents, not for you guys. So this is immune lung injury. Okay, so patient will have severe hypoxemia, and when we do a chest x-ray, we will see bilateral infiltrates. Okay, patient will have bilateral in chest infiltrates. There is no sign of fluid overload in the patient. The signs of fluid overload, I will explain it here. There is no signs of fluid overload. The patient will have fever because it is injury, lung injury, so patient will have fever, patient will have hypotension. So BNP is not elevated. This is a sign of overload, like BNP is not elevated, and there is poor response to diuretics. In this case, in case of trolley, we will not give diuretics to the patient because there is no circulatory overload. We will give oxygen support, ventilatory support to the patient. Okay, then it's TACO. In case of TACO, patient will be maybe an elderly male or female having some hypertension, some cardiac anomaly problems, or some renal problems. So when we say that we have given a second or third unit, so patient developed symptoms of dyspnea. Okay, so these patients, as it is a circulatory overload, so patient will present with hypertension. Here we have hypotension and fever. Here is no fever. Patient has dyspnea with hypertension because of the overload. JVP is raised. S3 is audible. Okay, patient will have a peripheral edema, and when we do an X-ray, we will see like there is cardiomegaly and pleural effusions. Okay, pro-BNP is increased in this case more than 1.5 times, and as it is a circulatory overload, so patient will improve quickly if we give the diuretics. Okay, so then is acute hemolytic transfusion reaction, which is actually immediate. In this case, patient will have fevers. Okay, fever also was also in trolley. He has fever, chills, back and flank pain. Okay, back and flank pain, hemoglobinuria. We will take, if there is transfusion reaction, we have to take the first urine after the transfusion, so we will see if there is hemoglobinuria or not. Hypotension. Okay, so it have hypotension, that is positive in this case. Okay, because it is an acute hemolytic transfusion reaction, so that will be positive. LDH increased, haptoglobin low, and dyspnea is not the primary feature in this case. In these two, dyspnea is the primary feature. In this case, yes, patient will have shortness of breath, but it will not be a primary feature. He will have these fever, chills, back pain, flank pain, hemoglobinuria, and all these type of symptoms. Okay, then in all these cases, what we have to do, first step is we have to stop the transfusion, but we have to keep the IV line maintained with saline. Okay, and we have to do chest x-ray because we have to see it is circulatory overload or trolley or TACO, and we have to see the vitals, it is hypertension or hypotension, JVP, we have to send proBNP, and we have to do the markers of hemolysis, we should know about that. We have to do that and inform the blood bank about all this. Okay, so just remember that in trolley When a trolley is suspected, the treatment is you have to give oxygen and ventilatory support to the patient. Okay, so avoid diuretics, and in case of taco, IV diuretics are given. Okay, and further transfusion should be slow, and consider split units, like we should not do overload bags at the same time. Okay, so we have to see that patient don't get circulatory overload. So this is according to this, I think so taco can be also be the answer, and trolley should be also, trolley is also there. So just for me both are correct, and we will see like what if it comes in the exam, so what is the whole scenario. Okay, so I hope you got the concept here. Okay. 421, a 5-year-old boy is brought to the clinic because of feeling fatigue for the past 3 weeks. Okay, he had acute onset of fever and just about 3 hours ago. Okay, acute. 1 month ago, the patient had history of travel to Asia because in the malaria endemic area, so he received chloroquine prophylaxis prior to his trip. Physical examination is remarkable for pallor and splenomegaly. Hematocrit is 21, leukocyte count is raised, platelet count is low, blood smear are conducted, and shows the darkly staining regions within the red blood cells. Okay, it shows like patient have like those blister cells, contracted cells. Okay, what is the most likely diagnosis in this patient? So this patient here the trigger is chloroquine. Okay, and because of the oxidative stress, patient had got hemolysis, hemoglobin is low, hematocrit is low, and he has this cells in the peripheral blood smear, so it is a case of G6PD deficiency. Other symptoms like patient will have dark urine because of hemoglobinuria. Next is regarding the met hemoglobin reduction test, which statement is false. So this statement is false, that sample is coagulated blood collected in plain tube. No, we need the requires anticoagulated blood, not the plain. So this option is false. Okay, others are correct. Okay, a 32 years old male is diagnosed with UTI and is given sulfamethoxazole and trimethoprim. His physical past medical history is unremarkable and he takes no other medications. Soon after beginning his antibiotic therapy, he developed anemia and notices that his urine has darkened. Same. This drug is notorious for G6. If patient has G6 PDF deficiency, so it causes hemolysis. He is diagnosed as a case of G6PD deficiency. Okay, so this deficiency, G6PD deficiency is what? It is autosomal recessive, autosomal dominant, sex X-linked, or not an inherited. So it is option C correct here. Okay. Of a 30 years old male is on his way to travel to Africa to visit family and friends. He is given the appropriate vaccination and prophylactic medications prior to the trip. Okay, a week later he present to the emergency department with jaundice and complaints of dark urine. Labs are collected and is shown below. Hemoglobin is low, reticulocyte count is raised, so it shows as a hemolysis. Total bilirubin is 3.8, direct bilirubin 1, lactate hydrogen is normal almost. Haptoglobin is reduced, which shows like there is intravascular hemolysis. A peripheral smear shows is conducted and stained. You are likely to find all of the following on the peripheral smear except. Okay, so this is a case of G6PD deficiency again, and we see hemoglobin is less, reticulocyte count is raised. Okay, hemoglobin raised, haptoglobin low, so it's the intravascular hemolysis. It is a G6PD deficiency, and what we see in the smear, we can see the contracted cells, we can see mild fragmentation, we can see bite cells, blister cells, but we don't see acanthocytes here. Okay, so this is, we have to select D. Pyruvate kinase deficiency is a defect in, it is an enzymopathy. Okay, like G6PD deficiency, we have pyruvate kinase deficiency also. So it is a defect in glycolytic pathway, the last step of the glycolytic pathway in G6, where there is pyruvate kinase deficiency. Okay, so there will be reduced ATP, and the red blood cells are rigid and they go hemolysis. Next is pyrimidine 5 nucleotidase deficiency. So it is also an enzymopathy. It is also an enzyme of the RBC. It is characterized by all of the following except autosomal recessive. Yes, it is autosomal recessive. It has, it's a basophilic stippling in it, and we see reticulocytosis in this because like G6PD, it is also an the red cells will go hemolysis. So we will see reticulocytosis and mild to moderate anemia. So it is not an autosomal dominant inheritance. Pyrimidine 5 nucleotidase deficiency, but it is an autosomal recessive RBC enzymopathy, as I said earlier. It causes chronic non-spherocytic hemolytic anemia. Okay, spherocytic hemolytic anemia, and which is also inherited and is hereditary spherocytosis, and hereditary spherocytosis is autosomal dominant, not recessive. Okay, so in this case it is hemolytic anemia, chronic hemolytic anemia. There will be no spherocytes, and there will be basophilic stippling due to RNA degradation failure, often mimicking lead poisoning, but will normal with normal lead levels. Okay, so we have studied three enzymes: G6PD, pyruvate kinase, and pyrimidine 5 nucleotidase deficiency enzymopathies. Okay, and next is regarding hemoglobin F. All of the following are true except, so at birth HbF comprises 60 to 80% of the total hemoglobin. It is right. Okay, it will change it at 6 months of age. It will start switching over to hemoglobin A. Hemoglobin F is having low affinity for oxygen. No, HbF has high affinity for oxygen. It causes that curve to the left. Okay, there is a, you have seen like that is oxygen. Yeah, it is oxygen dissociation curve. So it will move the oxygen dissociation curve to the left. Okay, so it contains two alpha and two gamma chains. Yeah, it is right. It contains two alpha, two gamma chains. Level of hemoglobin F in heterozygous HF, we have discussed hereditary persistence of fetal hemoglobin. In that case, hemoglobin F is 10 to 35%, and in case of homozygous HPFH, the hemoglobin F will be almost 98 to 100%. Okay, so then level of HbF in heterozygous beta is 5 to 15. Beta trait or compound heterozygous beta is 5 to 15%. So this is also correct. Okay, so only this one is wrong. I will just want to tell you the correct one, because in this way you will memorize these things. Regarding alpha thalassemia, which of the following alpha thalassemia is not survivable? Okay, so alpha thalassemia, in alpha thalassemia, there is a deletion defect. Okay, so we have deletions of one gene deletion, two gene, three gene, or four gene deletion. So whenever there is four gene deletion, so the baby cannot survive. So this is and 4G, it is called hydrops fetalis. Okay, so it is not compatible with life. So silent carrier is completely okay. Alpha thalassemia minor is okay. In HPH patient usually presents with chronic hemolysis, but the phenotype is like thalassemia intermedia. This patient will get transfusions in life, whenever there is surgery or some injury surgeries, or whenever it is needed, but not like all the time, like we give in case of thalassemia major. So HBH always have a phenotype of thalassemia intermediate, not major. But this hydrops fetalis, it is completely incompatible with life. Okay, so which of the following statement is not a symptom of thalassemia disease? So it is. I just want to correct a little bit this one. So they say abdominal cramps, which is not a symptom of thalassemia disease. Abdominal cramps, slow growth and weakness. It is a It is, we see this in thalassemia. Okay, dark urine. Facial bone deformities and teeth deformities. So we see facial bone deformities, teeth deformities, slow growth and weakness in thalassemia. Okay, so dark urine, and they say dark urine is not a symptom of thalassemia, because dark urine usually tells us like hemoglobinuria type of thing, like there is hemoglobin in the urine. So dark urine, this option is correct, it is C. But this abdominal cramps, in usually in thalassemia we don't have cramps. Okay, we have abdominal pain or dragging sensation due to splenomegaly or hepatomegaly. So just it should be like abdominal pain here, not like abdominal cramps. Okay, the option is still C here is correct. Which of the following statement is not correct about beta thalassemia? Severity depends upon the mutation of genes. It is right. If it is beta naught, it is will more severe. If it is beta plus, so it is less severe. Okay, four globin genes are required to make beta globin chain, two from each parent. No, it is one from each parent. Okay, two from each parent is in case of alpha thalassemia. Beta thalassemia is also known as thalassemia major. It is correct. Beta thalassemia is common in Mediterranean region. It is correct. And excess, when in beta thalassemia we have excess alpha chains, but these chains value, they will precipitate in the erythroblast and mature red cells, and those cells will go hemolysis. So in this case we have ineffective erythropoiesis. Okay, so the option B is here. Okay, so just revise that only two beta globin chains will be there, one from each parent. Okay, not four. In if it is four, it is alpha, they are talking about then alpha globin chains. Next is 431. A 60 years old patient of CKD was advised IV EPO for anemia. EPO affects erythropoiesis through which of the following mechanism? Okay, so just uh, memorize this thing because it's a big pathway. So erythropoietin acts mainly on late BFUs. Okay, burst forming unit erythroid. It is written in Hofbrand in first chapter that when erythropoietin is stimulated, it will affect late BFUs and it will affect CFUE, colony forming unit erythroid cells, not the early one. Okay, and it promotes the survival, proliferation, and differentiation into mature erythroblasts. And erythropoietin acts via the JAK-STAT pathway, upregulating BCL, XL, an anti-apoptotic protein that promotes survival and differentiation of erythroid progenitor cells. Okay, so it promotes this one, so the anti-apoptotic, so apoptosis will not occur, so there will be more survival and differentiation of erythroid progenitor cells. So here just go back. So what is the mechanism of EPO? EPO acts via JAK-STAT pathway in inducing or stabilizing anti-apoptotic protein BCL-XL. Okay, so this is option is correct for EPO. Next is a 2 years old girl, product of consanguineous marriage, presented with pallor, hearing difficulty, and polyuria. Okay, so her bone marrow examination revealed ring sideroblast. She is likely to respond to which of the following. Okay, so look just here that patient have ring sideroblast, she has pallor, she has hearing difficulty, and polyuria. So just looking into these options, we will go like it looks like a case of thiamine responsive megaloblastic anemia or Rogers syndrome, because patient have hearing difficulty, diabetes mellitus, and issuing ring sideroblast. Okay, so it is a case of the option D is correct. It is TRMA or Rogers syndrome. Okay, so next is 3 years old boy presented with failure to thrive, persistent diarrhea, metabolic acidosis, and transfusion dependency. Okay, so his peripheral blood morphology shows macrocytic blood picture. What is likely findings a hematologist should suspect while examining his bone marrow smear? Okay, so failure to thrive, persistent diarrhea, okay, metabolic acidosis, transfusion dependency in a 3 years old boy. So what it points us, it's the megaloblastic change in the erythroid lineage. No. Sideroblast, what we will see in the bone marrow, sideroblast and prominent vacuoles in the myeloid and erythroid lineage. Yes, this one is correct. Okay, because it is a case of Pearson syndrome. Okay, binuclearity on erythroid lineage, it is seen in case of CDA, not here. Hypoplastic biopsy, all of the above. So option B is correct here. It's Pearson syndrome. In Pearson syndrome, just remember 3 P's. Pancreas is involved. Patient will have pancytopenia and power failure, like some large DNA deletion defect in mitochondria. Okay, so patient, that's why will have failure to thrive. Okay, pancreatic insufficiency, so patient will have persistent diarrhea, metabolic acidosis, and then transfusion dependency because of the pancytopenia. In their bone marrow, we will say vacuolated precursors. Okay, vacuolated precursors in the myeloid and erythroid lineage. Ring sideroblasts are seen in the bone marrow, usually presents in infancy, less than 1 year, with anemia, failure to thrive, and steatorrhea. Okay, these are the symptoms. Just remember 3 P's with Pearson, vacuolated precursors, pancytopenia, and whenever there is pancreatic insufficiency, so you will see these type of symptoms, steatorrhea and diarrhea. Okay, many die early due to metabolic acidosis, infections, or bone marrow failure, because it is a bone marrow failure syndrome. We have a pancytopenia, so most babies die early. Okay, so Pearson, you should remember with these 3 P's. Next is a 45 years old male presented with lethargy, gray skin, joint inflammation, diabetes, and ascites. Okay, so just when it is gray skin, diabetes, ascites, lethargy, so which of the following phenotypic findings are suspected in this molecular study? Reveals homozygosity for PC28Y HFE gene. So whenever there is mutation in this gene, it is a scenario for hemochromatosis. Okay, or but which option is correct here? Okay, so the option is A, it is an autosomal recessive, and in this case there is parenchymal iron overload. Okay, okay, next is A 15 years old girl, known case of beta thalassemia major on regular chelator, was found to have neutropenia on routine CBC report. Which of the following chelators is responsible for that? These three are chelators of iron. So the option here is deferriprone. Just remember, like deferriprone, prone to cytopenias or prone to neutropenia. So neutropenia is associated with deferriprone. Okay. Next is, following are the nutritional aspects of folate in the body, except it is found in green liver, green leafy vegetables, and yeast. It is weakly bound to albumin. These all are correct. It is absorbed in the ileum. No, it is absorbed in the jejunum. Okay, 10 to 12 milligram is sufficient for 4 months. Yes, and anticonvulsants decreases absorption. It is correct. So the wrong one is option C. Which of the following hematological findings are seen in case of megaloblastic anemia? So in case of megaloblastic anemia, we see a slightly reduced WBC count, increased MCV with spherocytes. No, we don't see any spherocytes. Okay, a low reticulocyte count, hypercellular bone marrow with giant granulocytic precursors and erythroid, and hyposegmented neutrophils. Which of the following are seen in cases? So this is seen. Okay, hypercellular only we will see, like metamyelocytes, giant myelocytes, and metamyelocytes, and in erythroid. Okay, we will see nuclear acytoplasmic incident because of immaturity. These all are MCV. We don't see spherocytes, and the reticulocyte count is low in megaloblastic anemia because there is ineffective erythropoiesis. So when there is ineffective erythropoiesis, the reticulocyte count is low. So this scenario is little bit weird because because these are, I think so, just recalls or something. So there may be some problems in the scenarios. So just learn the whole concept, so you can answer any question like that. So in megaloblastic anemia, the reticulocyte count is low because we have ineffective erythropoiesis. The cells die because they are immature. They go 15 to 20% cells die before coming out, and the reticulocyte count will be low. Yes, when you give a B12 or folate to that patient, so there will be brisk increase in reticulocyte count in 3 days, and you will end the because of the response of the marrow. It shows that like the cells are now maturing. Okay, so that's where reticulocyte count will improve. Okay, so MCV is increased in case of megaloblastic anemia, but there are no spherocytes. It is right. Slightly reduced. Yes, in megaloblastic anemia, we have reduced. A patient can present with pancytopenia. So WBC count, hemoglobin, and platelets are reduced in megaloblastic anemia. Okay. So hyposegmented neutrophils. Yes, it is completely wrong. We have hypersegmented neutrophils. So just learn the concept and then you can answer by your own. So the one which is correct is hypercellular bone marrow with giant granulocytic precursor and erythroid precursor. Okay, a 16 years old girl is pale on examination with mild splenomegaly and HB is 8. On CBC, she is on inquiring, she is transfused twice in past 4 years. Okay, so not regularly transfused. However, her transfusion requirement is slightly increased in the last few months. On the basis of clinical details, she is likely to suffering from beta thalassemia major. No, needs regular transfusion. Beta thalassemia trait, it don't needs any transfusion. Thalassemia intermedia, yes, it can be a case of thalassemia intermedia because hemoglobin is like that, and she has mild splenomegaly and transfusion, less transfusion. Okay, so it is a case of thalassemia intermedia. Next is the genetic modifiers of beta thalassemia phenotype, which affects the degree of globin chain synthesis imbalance, are classified as last in my last video I told you in detail. Just revise from there are three modifiers: primary, secondary, and tertiary modifiers of thalassemia. Okay, which on which the thalassemia phenotype will be changed. Like two persons having same beta, both will be having thalassemia major, but their transfusion requirement is different, their chelation requirement is different. Okay, and that is because of the modifiers of thalassemia. So it is important for heme residents, not for others. So primary, secondary, and tertiary. In this case, when they are asking that beta thalassemia phenotype effects when degree of globin chain synthesis imbalance are classified as, so it comes in secondary modifiers, because in case of secondary modifiers, HbF, there are certain mutations in which HbF is increased, and when HbF is increased, the severity of thalassemia will decrease. Okay, so next is 440, a condition in which reduction in proportion of HbS is required in a patient with sickle cell disease include all of the following except. So option here is In it is HBS, patient has sickle cell disease. So the patient will have what? He can have cerebral stroke. Okay, he can have acute chest syndrome. He can have persistent priapism. That is right, but he don't have aplastic crisis. Okay. In this case, patient can have parvovirus B19 infection, and there will be pure red cell aplasia. Okay, but not aplastic anemia, not aplastic crisis. It is okay. A 7 years old girl came with pallor and abdominal distension. On examination, she has mild jaundice. Her CBC showed microspherocytes and increased reticulocytes. Combe test was negative. Okay, which of the following investigation would help to reach the final diagnosis? So this is a case of hereditary spherocytosis, because you see the spherocytes in the peripheral smear, you see increased reticulocyte count, which tells us that it is a case of hemolysis. And then Coombs was negative, so Coombs is positive. If it is positive, so it is autoimmune hemolytic anemia. While hereditary spherocytosis, hereditary elliptocytosis, these are not in this case. Coombs are negative; they are non-autoimmune hemolytic anemia. Okay. So in this case, they are asking like which investigation which help to reach the diagnosis. So it is osmotic fragility test. We could do in and in osmotic fragility test, it will be increased in case of hereditary spherocytosis, because the cells are fragile, they break easily when the cells are placed in a hypotonic solution. The water will come from the it will enter the cell from a like solute concentration to high solute concentration. So when the water will come inside the cells will burst uh, more early than the normal cells. Okay, normal cells are a little bit more because they have more surface to volume ratio, because those cells, the normal cells are biconcave in shape. So when the water will come inside, they can resist to a certain extent. But the cells, if they are already spherocytic, they are small, so they will not resist and they will burst. Okay. Spherocytes plus negative comb, osmotic fragility test is diagnostic, hereditary spherocytosis. Next is 442. A 26-year-old female, known case of SLE, presented with sudden onset of pallor on examination. She has splenomegaly. Okay, on examination, she has splenomegaly. CBC shows hemoglobin is 6. She has with agglutinates and microspherocytes on the peripheral film. Which of the following investigation would you prefer in her workup? Okay, so this patient is a case of, it is like she has SLE and autoimmune disease. So it can be a case of autoimmune hemolytic anemia. In autoimmune hemolytic anemia also we have microspherocytes, we have agglutinates. Okay, so which test we will do? In that case, they already have given Coombs test. Okay, so we have to differentiate. When there is microspherocytes, we have to differentiate that it is autoimmune or not, or non-autoimmune. So we will go for Coombs test. Okay, the Coombs test will come out positive in case of autoimmune hemolytic anemia. Next is a 32 years old pregnant lady presented with history of lethargy and breathlessness. On examination, she was diagnosed as a case of iron deficiency anemia, and she was prescribed oral iron supplements. Which of the following factors favor iron absorption? So it's an easy one. Which ferrous form of iron is readily absorbed? Okay, and we need an acidic pH. We need decreased hepcidin, because when hepcidin is decreased, iron will be absorbed from the enterocytes. So and heme iron is readily absorbed. Okay, so which of the following factors favor iron absorption? It is here ferrous form of iron is readily absorbed. But in case of heme and non-heme iron also, so heme iron is better for absorption, not the non-heme iron. Okay, and T is like opposite of that. T phytates alkaline pH, they reduces the absorption of iron, and acidic pH and ferrous form of iron is readily absorbed. And next is a patient with SLE, hemoglobin 7 gram per deciliter, raised bilirubin levels, Coombs test positive. What is the treatment in this case? Okay, so if the patient is has autoimmune disease, so in case of autoimmune and she has autoimmune hemolytic anemia, so what is the treatment? We have to give her immunosuppressive therapy. So we will give her steroids. Option D is correct here. Permanent cure for aplastic anemia before 35 years of age. If patient is less than 35 years of age, we will go for allogenic stem cell transplant. To differentiate between iron deficiency and anemia of chronic disease, the best option I discussed earlier, it was a detailed topic before, so it is soluble as STFR. Okay, soluble STFR is the it is soluble transferrin receptor. Okay, so it is elevated in IDA, not in anemia of inflammation or chronic disease. So it is STFR will clearly differentiate between IDA and ACD. Next is a 14-month girl presented, she has pallor, jaundice is absent. Okay, jaundice is absent. High arch palate, limb abnormalities, so anomalies are here. Normocytic, normochromic anemia, erythroid hypoplasia on bone marrow, so some bone marrow failure thing is here. What is your diagnosis? Okay, so she is a 14 months old girl. She has erythroid hypoplasia. Okay, erythroid hypoplasia, it means others are correct, others may be correct. So they just told us about erythroid hypoplasia. What is your diagnosis? The options are CDA type 2, Schwarman Diamond syndrome, DBA, Diamond Black Fan syndrome, and dyskeratosis congenita. Okay, so here option C is correct, because whenever there is isolated just erythroid hypoplasia on the bone marrow, we will say it is a case of DBA, Diamond Black Fan syndrome, congenital erythroid aplasia or hypoplasia, plus there will be skeletal defects and normal MCV, normocytic normochromic anemia. DBA is a bone marrow failure syndrome, okay, in which we have erythroid hypoplasia. But in case of CDA is not a bone marrow failure syndrome. It is a congenital dyserythropoietic anemia. In this case, we have anemia due to some dyserythropoiesis. The erythroid cells are produced normally. Maybe we have erythroid hyperplasia in this case, but these cells are not normal cells. They die before leaving the bone marrow, okay. So we have ineffective erythropoiesis. In this case, we will have binucleated and multinucleated erythroblasts, and we have distinct ultrastructural abnormalities seen in the erythroblast under the electron microscopy. And patient will have mild to severe anemia, jaundice, splenomegaly, and iron overload due to ineffective erythropoiesis. So it is they are not hemolytic, but rather ineffective erythroid maturation disorder. Okay, not a bone marrow failure disorder. So just remember in CDA, remember from C, it is a crowded marrow. Okay, crowded marrow, it will be hypercellular, it will have dyserythropoiesis, and because of that we will have anemia. And in DBA, it is a pure red cell aplasia, and there will be erythroid hypocellularity. Maybe the bone marrow is normal because WBC's platelets are not produced normally, but and maybe it is slightly hypocellular, but erythroid will precut the erythroid. If we see the erythroid lineage, so there will be erythroid hypoplasia. Okay. And in Fanconi, there is anemia or aplastic anemia. There is global hypocellularity. Bone marrow will be hypocellular. Okay, it's a true marrow failure. Next is a 9 years old girl present with epistaxis, fever, and altered consciousness for the past 2 days. Her CBC showed hemoglobin of 7.1, WBC 11, platelets 23. So everything is low. It's a pancytopenia. Reticulocyte count is 4.3. It is raised. So there is some hemolysis. And peripheral smear shows red cell fragmentations. Okay, so just see, she has a fever. All the criteria of pentad is there: fever, altered consciousness, pancytopenia, she has cytopenias, reticulocyte count is raised, she has schistocytes, fragmented RBCs, and anemia is due to what? It is due to microangiopathic hemolytic anemia. So it is microangiopathy. Okay, then is 449, a 15-year-old girl was referred to hematology clinic with pallor and jaundice. There is no history of blood transfusion. Okay, her family history revealed similar presentation in the father. History: CBC showed WBC count of 7.5 is normal, hemoglobin is low 9.3, platelets are normal, MCV 95, MCH 31, MCHC 36. Reticulocyte count is 12. Okay, so reticulocyte count is raised. Some type of hemolytic anemia, some type of hereditary thing is there. Ultrasound abdomen showed gallstones. Okay, peripheral blood film revealed small cells lacking central pallor. Again, it is telling us spherocytes, and presence of polychromatic cells, which is because of the increased reticulocyte count. We see polychromatic cells in the peripheral smear. Direct and indirect Coombs tests were negative, both. So it is a non-autoimmune. What is the most likely diagnosis? The most likely diagnosis is here is hereditary spherocytosis, because family history is positive. It is autosomal dominant disease. Patient will have pigment gallstones stones because of the increased extravascular hemolysis. Combe test is negative, high MCHC. Okay, so this is a case of hereditary spherocytosis. A 11-year-old boy presented to pediatric OPD with fatigue, shortness of breath, and history of repeated blood transfusion after every 2 to 3 months. On physical examination, he has mild jaundice, pallor, spleen was palpable 4 cm below the costal margin. The spleen is enlarged. Patient have jaundice, pallor, so it shows about some type of hemolysis is going on. CBC revealed TLC of 7.5, hemoglobin is 7.3, anemia. Platelets normal, MCV 88, MCH 31. Reticulocyte count is 1.8. It is low. Reticulocyte count is low. Okay. So his hemoglobin electrophoresis was normal. Bone marrow examination revealed erythroid hyperplasia. Okay, erythroid hyperplasia is there with marked erythroid binuclearity and increased iron with sideroblasts. Okay, with sideroblasts and few rings sideroblasts and few are ring sideroblasts. What is the most likely diagnosis in this patient? Okay, so the most likely diagnosis in this patient is CDA type 2. In CDA type 2, we have erythroid hyperplasia. Okay, they are telling us erythroid hyperplasia and most are binuclear forms. In type 2, just remember 2 and bi. So binuclear forms are seen in type 2 and there are ring sideroblasts. Okay, so just see like reticulocyte, there is erythroid hyperplasia but reticulocyte count is low. So reticulocyte count is low in that case when there is ineffective erythrocytes, like there are a lot of production of cells, it's increased, but those cells are not completely going maturing because reticulocyte count, after reticulocyte stage there is mature red blood cells. So reticulocyte, if there is ineffective erythropoiesis, so cells die before reaching the reticulocyte stage. So that's why reticulocyte count is low whenever there is ineffective erythropoiesis. I told you in megaloblastic anemia also, in MDS also, that there is ineffective erythropoiesis, so reticulocyte count will be low. Okay, so I just wrote there here just to revise the concept. So ineffective erythropoiesis, binuclear or multinucleated erythroblast, depending upon type 1, type 2 or type 3. Okay, in type 2 we have binucleated, in type 3 we have multinucleated erythroblasts. Okay, next, a 19-year-old male was referred to hematology clinic for evaluation of mild anemia incidentally found on routine CBC. Physical examination was unremarkable. CBC revealed TLC of 7.4, hemoglobin is 11, platelets 212, RBC is 5.9, MCV is 60, MCH is 21. So it is microcytic hypochromic anemia. Patient have mild anemia. Okay, no physical examination unremarkable. So reticulocyte count is 1.2. Okay, so serum ferritin was 95. So it is microcytic hypochromic anemia, but iron serum ferritin is normal. Hemoglobin electrophoresis is also normal. The hematologist advised genetic testing for the confirmation of the disease because hemoglobin, when hemoglobin electrophoresis is normal, the next thing we have to do is to do the PCR for beta or alpha thalassemia. So what is the most likely diagnosis in this case? If there was a beta thalassemia trait, HbA2 is more than 3.5. Okay, if it is a delta beta thalassemia trait, HbF was around like 15 to 20%. If it was iron deficiency anemia, so it could serum ferritin would be low in that case, but serum ferritin is all normal here. So alpha thalassemia trait, yes, it can be a case of alpha thalassemia trait because the picture is like alpha thalassemia. There is a relative erythropoiesis. RBC count is increased in this type of anemia. Like if the hemoglobin is 11, it should not be 5.9. So when hemoglobin is low and there is a relative erythrocytosis and microcytic hypochromic picture, hemoglobin electrophoresis is normal. So it all points towards alpha thalassemia trait, and we can confirm it on by doing the PCR, like it is if it is one gene deletion or two gene deletion or what. Okay, so we for alpha thalassemia confirmation we will go for PCR. A 4-month-old male baby presented with pallor and failure to thrive. CBC revealed hemoglobin of 3.7. Okay, so it is too low. Platelet 159, TLC normal. A peripheral smear showed macrocytic RBC morphology. Hemoglobin electrophoresis showed HB of 89, HbA is 89, HbF is 9.1, HbA2 is 1.9. Erythroid ADA levels were raised. Okay, and bone marrow showed normal cellularity. Myelopoiesis and megakaryocytes are like normal, and there is less than 5% erythroid precursors. So I think so we discussed this in detail. Just to revise the here, so it is a case of DB8, okay, pure red cell aplasia. In this case we have less than 5% erythroid precursor. It is a bone marrow failure syndrome in which there is failure of erythroid lineage, okay. And in this case, just remember, in DBA HbF is always raised. You have, it is not a case of thalassemia or something you see like HbF is raised, just put in there. You have to see all the symptoms of that. HbF is 9.1 here. And the other clue is erythrocyte ADA, adenosine deaminase activity. In case of DBA, it is an enzyme which is seen in RBCs and it is raised in case of DBA. So, the other thing which I want to tell you, like thalassemia major, it is not a case of thalassemia major, because in that case HbF is quite increased, okay, maybe 70% or like 80%. So, or even more than that is the in HbF in thalassemia major, HbF is increased. So others are not related. So it is a case of DPA. In CDA, it is not, there is this, we don't do this erythrocyte ADA test, and that is normal in case of CDA, okay. And in case of CDA, there is just this erythropoiesis is there, okay, and the bone marrow is normal. There is no hypoplasia in that. Next is a 3-year-old boy presented with complaints of recurrent infections, bruising, and pallor. On examination, there was no visceromegaly. CBC showed hemoglobin of 7.1 and MCV is increased. Okay, so it can be a case of macrocytic anemia. Platelets are 85. ANC is the 3.4. Peripheral smear showed macrocytosis and neutrophil hypersegmentation. So it is telling here it is a case of megaloblastic anemia, and which tests would help in supporting your diagnosis. So they are homocysteine and MMA levels, serum homocysteine and methylmalonyl CoA levels. Okay, so this will help in the diagnosis of those tests, though we don't do it, but these are the diagnostic tests. 10-year-old girl has been receiving regular blood transfusion for a hemoglobin disorder. She's a resident of rural area and has not received any iron chelation. Okay, which of the following organs are most likely to be involved in this case of iron overload? So the most commonly involved organ is liver and heart, and we do T2 MRI for that. Next is 22 years old female presented with lethargy and fatigue. She has been receiving anti-TB drug, okay, for the past 4 months. She has hemoglobin of 7.5, okay, so there is anemia, and TLC platelets normal. Peripheral smear shows macrocytic RBC morphology. Which of the following is the likely diagnosis in this patient? Iron deficiency anemia. No, it is not a case of iron deficiency anemia, okay, because macrocytic RBC morphology. So it is a case of sideroblastic anemia, because they told us that patient is on anti-TB drugs. So isoniazid causes pyridoxine deficiency, and pyridoxine deficiency causes acquired sideroblastic anemia. So when we have to give pyridoxine to the patient. So in this case, the option B is correct here. And next is a 5-year-old male child was brought by his mother to OPD with complaints of fever and pallor for the past 3 months. The dietary history showed strict vegetarian diet. Again, the history strict vegetarian diet is like you have to go see for megaloblastic anemia. There is no history of blood transfusion. CBC showed TLC of 1.4, HB 10.2, MCV raised. Okay, so I told you before, like whenever there is a case of megaloblastic anemia, you can expect that in severe megaloblastic anemia the TLC count will be low. The patient can present with pancytopenia. So his vitamin B12 levels were low. On examination of bone marrow aspiration, which of the following is least likely to be found in this case? So when we do bone marrow examination, so what we will which is least likely to be found, okay, so what we will not found is the hypocellular marrow. So in megaloblastic anemia, bone there is the bone marrow is hypercellular, okay, so we will not see this feature here. Yes, we will see mild dysplasia, okay, giant metamyelocytes, giant myelocytes, we can see them in the bone marrow. A 3-year-old boy was markedly pale on examination and had mild splenomegaly. His peripheral film show Heinz bodies. Which of the following investigation would help in the diagnosis? Okay, so for Heinz bodies, we do heat instability test. Okay, EMA binding we do in hereditary spherocytosis and elliptocytosis, and osmotic fragility is also for hereditary sphero and elliptocytosis. Okay, so a 32 years old male patient presented with complaints of recurrent episodes of UTI. His brother died from the severe chest pain at the age of 12 years. HB was 10.8. Which of the following is not a feature of most likely underlying disorder? So this is a case of sickle cell disease, okay, or sickle cell trait, okay, because in sickle cell trait you have the complication of urinary tract infection, and the other brother died of a severe chest pain, so he may have sickle cell disease. Okay, so which of the following is not a feature? So hemoglobin electrophoresis, yes, when we do hemoglobin electrophoresis, there is a band in SDG region. Yes, that is right. Reduce the risk of Plasmodium falciparum infection, that is also correct. Symptoms usually aggravate in stress, it is correct. Frequent sickle cells are seen on peripheral blood film examination, it is wrong, because when it is a sickle cell disease, then only you can see the sickle cells in the peripheral blood smear. Usually in sickle cell trait we don't see sickle cells in the peripheral blood smear, okay. And positive cells test with sodium and metabisulfite, so it is a correct one, okay. And next is a 6-year-old girl presented with severe pallor. Peripheral smear shows anisocytosis, target cells, and occasional sickle cells. You have advised her high performance liquid chromatography (HPLC). What findings are likely to be seen in HPLC in this patient? So, in HPLC, when there is sickle cells, sickle cell disease, we will see a peak. Okay, in HBS window, that is around 4.2 minutes. Okay, just remember this thing, because HPLC is again a separate topic. I want to explain that, but it will take a lot of time and we will not be able to complete these MCQs. So just remember that in case of HPLC, you remember you will see a peak at in HBS window. Okay. Next is a 30 years old male presented with sudden onset of pallor and jaundice after he took antimalarials. Okay, again antimalarials he took it, and it is also a case of G6PD. Okay, his reticulocyte count is 6.7, supporting hemolysis. G6PD deficiency. You performed a G6PD assay, yeah, which came out to be normal. What is the likely reason behind this finding? So it is a case of G6PD deficiency, and when we do the test, the G6PD assay, so it came out to be normal. What is the reason for that? So he is not suffering from G6PD deficiency. False negative result due to raised reticulocyte count. Yes, this is option is correct, because when after the crisis, after hemolysis, all the red cells have been hemolyzed. So bone marrow will produce more and more young cells, and these young cells have higher concentration of G6PD. Okay, so that's why if you do a test just after the crisis or acute attack, so G6PD assay will can come out to be a normal, which is a false negative test. So that's why when the crisis are over, then you can check for G6PD deficiency, okay, not in the acute attack. Okay, a 75 years old male presented with purplish skin, again the same discoloration on exposure to cold. His hemoglobin was 8, MCV is 110. Ultrasound abdomen shows lymphadenopathy, and he was suspected to case of LPD, lymphoproliferative disorder. So lymphoproliferative disorder is associated with cold agglutinin disease, okay, and patient will have agglutinations on the peripheral blood smear, due to which MCV is falsely increased. And which of the following is likely finding in this patient? So what we will see in his peripheral blood smear, we will see red cell agglutinates, and it is a case of cold agglutinin disease. You need to keep the patient warm. Okay, next is a 44-year-old man presented in OPD with fatigue, weight loss for the last 3 months. His ANA profile is positive. Okay, hemoglobin is 12, MCV 78, reticulocyte count 4.3, reticulocyte count is raised, WBC count normal, and platelet count normal. Which of the following findings may be seen in his peripheral blood smear? Okay, so this is an autoimmune hemolytic anemia case, because here they say ANA is positive. So we can, what we can see, spherocytes, okay, in his peripheral blood film, and that is a warm autoimmune hemolytic anemia. If we do the DAT, so that will be positive in this case. Next is a 3-year-old boy presented with epistaxis and petechiae on forearm. He had low levels of CD42, okay, CD42, GP1B receptors, okay, on the platelets. Which of the following is seen in this disorder? Okay, so high platelet count, giant platelets, aggregation with ristocetin, defect in glycoprotein 1B2A, and normal bleeding time. So it is a case of whenever there is low level of CD42 on immunophenotyping or flow cytometry, so it is a case of Bernard-Sollier syndrome, and Bernard-Sollier, the other symptoms are giant platelets. If there is thrombocytopenia, and the platelets which are in are giant size platelets, just maybe the size of a RBC also. Okay, so and the other thing, it when platelet aggregometry, there is no aggregation to when aristocytin is added, so there is no response to erythrocytin. Okay, a 10-month-old boy, Ashkenazi Jews. Okay, so whenever this population is given, or so just think of factor hemophilia C, factor 11 deficiency. Okay, just a clue. Next, we will see. So this he is referred to hospital's emergency department for an episode of syncope. His medical history shows that he had circumcision performed 12 days earlier. The surgery was complicated by the appearance of penile hematoma. Okay, there was some bleed. His investigation revealed HB10, it is anemia, WBC count, platelet count normal, PT normal, APTT is prolonged. Okay, so APTT is prolonged and TT is normal. So what is the clinical suspicion? Vitamin K deficiency. In vitamin K, we have both PT and APTT prolonged. So this is not lupus, anticoagulant is not there. Patient is bleeding. So he has not a thrombotic disorder. Factor 11 deficiency, or most probably factor 13. In factor 13, everything is normal. PT, APTT will be normal. And in fibrinogen deficiency, PT, APTT, TT will be prolonged. Both all will be prolonged. Okay. So this is a case of factor 11 deficiency. Okay. Hemophilia C, PT normal, APTT raised, and the patient has a bleeding in 11, factor 11 deficiency. Patient don't bleed like hemophilia B and hemophilia A. They bleed after whenever there is some surgery or some injury, then patient will bleed. Okay. Next is a 9-month-old baby boy had prolonged bleeding after circumcision. His lab investigation confirmed diagnosis of hemophilia A. Which of the following feature statement is a feature of hemophilia A? Okay, a negative family history exclude the diagnosis. No, females are as affected. No, because male are more affected, though females can be affected, but males are affected more. Mucocutaneous bleeding is common. No, it is has a deep bleeding. The extent of factor A deficiency correlates with the clinical bleeding. This is correct. But it tells us if the factor deficient if the factor is less than 1, so patient will have severe deficiency. If the factor is more than 5%, so patient will have mild deficiency. So the clinical or phenotypic picture is correlating with the factor levels. So option D is correct here. And the diagnosis of we will do with APTT, not with prothrombin time. Okay, a 35-year-old female nearly bleeds to death during an elective hernia repair. There is history of regular intake of medication. What over-the-counter drug was probable cause of bleeding in this patient? So the bleeding in this patient will be because of the aspirin, acetyl salicylic acid, because it irreversibly blocks the platelets. Okay, so platelets are blocked for their lifetime, like 7 to 10 days platelets will be blocked. So we have to stop the patient from taking aspirin before we go for the surgery. A 8-year-old female with recurrent tonsillitis was referred for a tonsillectomy with no past bleeding history. Okay, she don't have any history. Her surgeon ordered pre-operative laboratory tests, and the results demonstrated a PT of 10.2 and APTT of 58. So APTT is prolonged in this case. Okay, and what is the most probable diagnosis? So it is a case of, I told you before also, it is a case of a test factor for 11, uh, uh, 11 or 12. No, it is a 12, because here they are saying no past medical history. If they have given a history of some bleeding history, then of course we will go for factor 11 deficiency. But as they are telling us, like there is, okay, wait. So there is no factor deficiency, there is no bleeding here. So it is a case of factor 12, Higman factor deficiency. Okay, so just remember, in factor 12, there is no bleeding. Okay, there is no bleeding, in spite the APTT will be very prolonged, but there will be no history of bleeding. Okay, you have to tell the surgeon like if it is factor 12 deficiency, so there is no risk of bleeding in that surgery for the patient. Next is labs investigation showed thrombocytopenia, deranged coagulation profile, and diagnosis of DIC was made. Which of the following is not associated with DIC? So amniotic fluid embolism, yes, it is associated with DIC. Sepsis is associated with DIC. Okay, a minor surgery after local anesthesia, yeah, it is not associated with DIC. Okay, so just local anesthesia and minor surgery, and patient cannot go into DIC because of that. Okay, so next is a blood film of 67 years old man revealed acanthocytes, macrocytes, oval jolly bodies, and mild thrombocytosis. Okay, so which of the following is associated with these features? So oval jolly bodies is associated with hyposplanism. So C is correct here. As 60 years old retired army officer presented with pain, abdomen, joint pain, and lethargy. Lab revealed hypochromic microcytic picture. Okay, increased TIBC points out towards iron deficiency anemia. Which is the following the most common cause in this age group? In this age group, the most important cause is GI bleed. Okay, gastrointestinal bleed. In kids, if there is age of 4, 5, 6 years, so in that case we will go for worm infestation. And next is a patient was treated with chloroquine for malaria, developed jaundice, peripheral show bite cells, and reticulocytosis. Which test will you do for confirmation of the diagnosis? So it is a case of G6PD deficiency, and we will go for G6PD screening test. Okay, so C option is correct. After that, Heinz preparation test. Next is a 35 years old female presented with gum hypertrophy and MEL is 6 months. CBC show HB is 8. Platelets is 88, bicytopenia, TLC is normal. Which of the following is a provisional diagnosis? So, if just for 6 months, okay, not a very vast history like it is 10 years or something. So, she has a from 6 month history, she has bicytopenia, gum hypertrophy. So, it can be a case of acute monocytic leukemia M5. Next is a 55 years old male presented with generalized weakness, splenomegaly, lymphadenopathy for 6 months. CBC revealed leukocytosis, peripheral film showed neutrophilia with prominent left shift and basophilia. Okay, whenever there is leukocytosis, neutrophilia with left shift means like we have myelocytes, metamyelocytes, the immature forms of the neutrophils we are having, and there is basophilia. So our provisional diagnosis will be chronic myeloid leukemia. Here in case we have leukocytosis, basophilia, and left shift. Okay, next is a 55-year-old male presented with generalized lymphadenopathy and splenomegaly. His peripheral film showed lymphocytosis with small, mature-looking lymphocytes and smudge cells. So whenever there is leukocytosis, okay, and elderly male lymphadenopathy, splenomegaly, and mature lymphocytes with smudge cells. So the statement, it is a case of CLL, chronic lymphocytic leukemia. Mature cells are there. So they are saying which of the following statement is correct. P53 mutation is associated. No, P53 mutation is never associated with good prognosis. Most of the patients are asymptomatic and requires treatment. It is wrong. These patients are usually asymptomatic and don't require treatment. Okay, absolute lymphocyte count is always more than 5. So this is correct, because there should be lymphocytosis and the absolute lymphocyte count should be more than 5,000. Okay, and ZAP70 carries a poor prognosis. You need to do a refined biopsy of a 26-year-old male. Which size needle is used? So for a 26-year-old male, we will take 11 gauge size. Okay, and for the infant, sorry, not the infants, for the uh, uh, like kids, we have to go for 13. Okay, so 13 is small, 11 is big. Okay, the main morphological features to distinguish between iron deficiency anemia and beta thalassemia trait is for between iron and beta thal, because both are microcytic hypochromic, both have target cells, both have anisocytosis, both have microcytes. So the thing which differentiate between these two is basophilic stippling, and it is more typical of thalassemia than IDA. Which of the following is best suited for community-based screening program? So it is just a revision of the previous MCQ. So for the community-based screening program, we do erythrocyte protoporphyrin. Okay, we don't do ferritin because it is an acute phase reactant and it is an expensive test. We cannot go for community-based screening for ferritin. And iron is we cannot do for iron because iron has a iron levels fluctuate from in the morning it is high, in the evening it is low. Okay, which of the following test is ideal for differentiating between IDA and ACD? It is soluble transferrin receptor, STFR. Next is elevated serum ferritin, serum iron, and TSAT are most consistent when this all will be elevated. It will be elevated when there is a lot of iron in your blood. So what is the diagnosis in that case? It is hemochromatosis. Next is which of the following is not a primary cause of IDA? Okay, so CRF Chronic renal failure is not a primary cause, because when it's chronic renal failure, it will there is a decreased production of EPO, and because of that there is a reduced EPO, and there will be a deficiency of iron. Patient will have microcytic hypochromic anemia. Okay, so this is not a primary cause. Which of the following is the earlier indicator of iron deficiency anemia? So the earlier indicator in this case: increased TIBC, decreased serum iron, decreased serum ferritin, and none of the above. So we do ferritin. Decreased serum ferritin will tell us about the stores of the iron before real iron deficiency anemia develops, because in the, you can see in many cases hemoglobin is around 12 or 13, but but when we do the serum ferritin, so it is like 20, 30, or and patient will have the symptoms of iron deficiency anemia, but it is considered like the hemoglobin is 12 and everything is okay, but that is not okay. You have to look for the stores of the iron, and for that you have to go for serum ferritin. Next is, which of the following is not a feature of Patterson-Kelly syndrome? It is also known as Plummer-Vinson syndrome. Okay, so the same name, and it is a triad of esophageal webs, iron deficiency, and dysphagia. Okay, so which is yeah, it is also there in that case, because in iron deficiency anemia we have these spoon-shaped nails. So which of the following is not a feature? So gum hypertrophy is not a feature. Which of the following is associated with macrocytic anemia? Okay, so with macrocytic anemia, copper deficiency is associated. Okay, it causes a sideroblastic anemia. Copper deficiency is zinc toxicity, so they are causes of sideroblastic anemia. Which of the following is the major cause of anemia in renal failure patients? In renal failure patients, of course, it is released from the kidney. 90% of EPO comes from the kidney, so low EPO levels. Next is, which of the following conditions is not associated with low EPO levels? So in polycythemia rubra vera, okay, EPO, we have suboptimal levels of EPO. CRF, low EPO levels. Okay, in autoimmune hemolytic anemia, because uh, uh, in autoimmune hemolytic anemia the EPO levels will be increased. Okay, so and in ACD, anemia of chronic disease, yes, because of inflammatory cytokines, it suppresses the EPO production from the kidneys. So these three have associated with low EPO levels, but in autoimmune hemolytic anemia, there is no problem in the kidneys, no problem in the bones, so there will be a lot of production of EPO, and a lot there will be erythroid hyperplasia, because bone marrow have to compensate for the hemolysis and to produce more red blood cells. Okay, which of the following is true regarding oral iron therapy? So yeah, just please remember this concept. This is important for the everyday life, not only for the exams. So for oral iron therapy, uh, option A, which of the following is true? Best given after meals? No, we should give it uh, empty stomach before meals, because it affects the absorption of iron. Yes, if the patient says that he has problem with iron tablets, then you can go for that person can take it with the meals, but it will decrease the absorption of iron. Enteric coated tablets are not helpful, because when they pass, when the coat is removed, until then the patient and the tablet will be in the, maybe in the jejunum or ileum, and the absorption site is duodenum. So enteric coated preparations are not helpful for the absorption of iron. Maximum dose is 200 milligram elemental iron. Yeah, it is correct. It is because the maximum dose is 200 milligram elemental iron, but and now the recent recommendations are like it should be not it should be like 100 to 150 milligram iron is enough, not go for that, but maximum dose is 200 milligram elemental iron, so this one is correct because of that. And vitamin C is not mandatory, it should be given, okay, but it is not mandatory, so option C is correct here. Iron is available in three forms: oral iron, ferrous sulfate, ferrous fumarate, and ferrous gluconate. It is 325 milligrams of iron tablet, and which 65 milligram is elemental iron. In ferrous fumarate, 300 milligram, and elemental iron is 100 milligrams. And in ferrous gluconate, 325 milligram is the salt, and which 36 milligram is the elemental iron. And elemental iron is the amount of pure absorbable iron which is present in a tablet or preparation. So this in this it is like a 325 milligram tablet, but only 36 milligram of elemental iron will be absorbed. and you will see the response if the patient is taking iron, and we will see the response in the form of increased reticulocyte count in 3 to 7 days. Okay, and hemoglobin will rise by 1 gram per deciliter every 2 to 3 weeks, and continue iron for 3 to 6 months. 3 months are needed for stabilization of hemoglobin, and then again the 3 months for to normalize or to refill the store. So it's a treatment for 6 months. Okay, avoid like when we are taking iron, so we have to tell patient to avoid from tea, coffee, calcium, antacids, and PPIs. Okay, and tetracyclines and levothyroxine, they all decreases the absorption of iron. Okay, so why the maximum effective dose for elemental iron in Hof brand, it is written like it is 200 milligram per day. Okay, so but we usually take lower than that, because the intestinal mucosa can and only absorb 20 to 25% of oral iron at one time. So where higher doses have no better absorption. Okay, and it have more side effects like nausea, constipation, black stools. So other just the intestine can absorb 20 to 25% of oral iron, and this much 200 milligram is the maximum dose, and it is still maximum. Okay, we have to give it to the patient like 100 to 150 milligram is enough. Elemental iron is, they are talking about elemental iron, they are not talking about the milligrams in which that elemental iron with the ferrous salt is available. Okay, so go just whenever you have to buy the tablet, just see but how much is the elemental iron in that tablet. Which of the following is true regarding serum iron and its concentration? Serum iron and its concentration. It is very stable. No, serum iron is not stable. It shows a diurnal variation. It is more in the morning and reduced in the evening. And transported in the ferrous form. No, that it is transported in the ferric form when it binds with the transferrin protein. And it is stored in the ferric form. Yes, iron is stored in the ferric when it is converted into the ferritin, and then it is stored in the ferric form. But here they are asking about serum iron and its concentration. They are not about asking about the storage form. So iron is indeed stored in the ferric form, but the question asks about serum iron and its concentration, not the storage. So but if they ask like storage form of iron, yeah, it is ferritin and hemosiderin in which iron is absorbed in the ferric form. Iron is transported in ferric form. Iron stored in storage form is also ferric form. The functional form, the usable form, which is in the hemoglobin, is in the ferrous form. Which of the following is true regarding hemosiderin? It is water soluble. Hemosiderin is water. It is not water soluble. It is insoluble. It is formed by complete. It is digestion of ferritin. So no, it is formed by incomplete digestion of ferritin. It has higher iron to protein ratio than ferritin. Yes, it has iron to protein ratio more than ferritin, and it's none of the above. So option C is correct for hemosiderin. Which of the following is caused due to mutation in matriptase 2? So it is porphyria cutaneous tarda, iron refractory iron deficiency anemia, sideroblastic anemia, or hemochromatosis. So the option here is iron refractory iron deficiency anemia. So whenever there is mutation in this gene, TMPR, TMPR SS6 transmembrane protease serine 6, whenever there is mutation in this gene, it encodes for matriptase 2. So there is mutation in this, and there is down regulation of matriptase 2, and it whenever it is down regulated or loss of function, it causes iron refractory iron deficiency anemia. In simple words, but what is iron refractory iron deficiency anemia? There is very high, inappropriately high hepcidin secretion in this. Whenever there is high hepcidin, there will be no absorption of iron from the enterocytes and from the reticuloendothelial system, from the macrophages. So in spite of having iron in the bone marrow, and in spite the patient is taking iron, there will be no iron in the blood, and patient will have iron deficiency anemia. And how we will know that patient will have iron deficiency anemia? Because if you give oral supplements to the patient, and after 6 months, if you see the patient has still have iron deficiency anemia, so in this case we will know that it can be iron refractory iron deficiency anemia. Okay, so what is the normal function of matriptase 2? When matriptase 2 normally it cleaves hemojuvelin. Okay, it cleaves hemojuvelin, and why the BMP SMAD signaling pathway, it suppresses the HAMP. HAMP is a for in code for hepcidin gene. Okay, so the signal to make hepcidin turns off. So whenever matriptase 2 it cleaves the hemojuvelin, hemp will be reduced and hepcidin will be turned off. When hepcidin decreases, there will be more absorption of iron, okay, from the enterocytes. And this occurs in case of iron deficiency anemia. Whenever there is iron deficiency anemia, metropitase 2 will be increased, released from the liver, and metropitase 2, by this all pathway, it will switch off the hepcidin or reduce the production of hepcidin. And in that case, what will happen, we will have increased absorption of iron from the enterocytes and macrophages. What happens when there is loss of function of the TMPRSS6 gene? There is defective metropitase 2 protein. It cannot degrade, which is the normal function of it is to degrade hemoglobin and hemp, okay. So it cannot degrade hemoglobin, and hemoglobin continues to produce hemp transcription, so there a lot of hepcidin will be produced. When there is hepcidin, it will not let absorption of iron from enterocytes and macrophages, and patient will have iron deficiency anemia. So this condition is called iron refractory iron deficiency anemia. Just to revise this concept, TMPRSS6 is the gene on chromosome 22, okay. There is a mutation in this gene, so after mutation in this gene, we have loss of function or reduced function of metropitase 2, okay. And this type of course, it reduces its function, so we will call it loss of function, and it is an autosomal recessive condition. In this case, hepcidin will be increased, iron absorption will be decreased. So this is IRIDA. I hope you get the concept here. Which of the following is not true regarding transferrin deficiency? So which of the following is not okay? Transferrin deficiency. So FFP is given for treatment. It is correct, okay, because transferrin is the protein found in the plasma. So if you have a transferrin deficiency and we give the patient FFP, so that patient will improve. IV iron is the preferred treatment. No, it is not, because the problem is in transferrin deficiency, the transporter of the iron, the truck of the iron. So if we give iron, so we don't have transferrin, so this is not the treatment for that. Tissue iron overload is a feature, no, results in hypochromic microcytic anemia. Okay, so this is correct. This is correct. Tissue iron overload, of course, when we don't have transferrin, there is iron overload. So which is not correct is that this one, IV iron is the preferred treatment. Okay, the preferred treatment should be like FFP. Which of the following statement is not correct? 1 unit of blood contains 200 to 250 milligram of iron. It is correct. 1 to 2 milligram of dietary iron is absorbed daily. It is also correct. 1 molecule of transferrin carries 4 molecules. So it is wrong. 1 molecule of transferrin contains 2 molecules of iron. C is correct. Which of the following organ is not routinely damaged by the iron overload? With the iron overload, liver is damaged, heart is damaged. Iron also deposits in the endocrine gland. So kidneys is the answer. Okay, a 1-year-old child presented with severe macrocytic anemia with subnephrotic range proteinuria. Okay, so if some baby has 1 year old and is a baby and has a macrocytic anemia and he has proteinuria, his vitamin, and we check the vitamin B12 levels, they are low. So what is the option here? It is Emerson-Grasbeck disease. We discussed this earlier, okay. So if proteinuria, with the help of proteinuria and vitamin B12 levels, you know that it is this disease, okay. Next is a 2 years old girl born out of a consanguineous marriage presented with pallor, hearing difficulty, and polyuria. CBC showed pancytopenia, and peripheral blood smear show hypersegmented neutrophils, prominent macrocytes, occasional polychromasia. So it is a symptom of megaloblastic anemia with some with some hearing difficulty and with polyuria, pointing towards the diabetes mellitus. Her bone marrow examination revealed ring sideroblast. This is correct. She is likely to respond to which of the following? So it is a case of thiamine responsive megaloblastic anemia, also called Rogers syndrome. In this case, it is an autosomal recessive, so you have a history of consanguinity, macrocytosis, ring sideroblast. Okay, in this case, we have to give large doses of thiamine, and because there is deficiency of thiamine transporter, so we have to give large amount of thiamine to this patient, and these patients will improve. Okay, so just I wrote it here. It's a rare autosomal order. That's why they have written about the marriages, cousin marriages history we have to take from the patient. And there is mutation in SLC19A2, which is a thiamine transporter. Okay, so patient will have a triad of megaloblastic anemia, diabetes mellitus, sensory neural deafness. So just remember TRMA and Rogers syndrome. Effective treatment of iron deficiency anemia results in normalization of hemoglobin and replenishment of iron stores, provided the cause of iron deficiency is also rectified. Okay, so we discussed earlier. So what is the average duration of treatment? Usually it is 3 to 6 months. What is the suggested daily dose of elemental iron? Now I have explained elemental iron to you, so you should know elemental iron is the iron which is the true dose of iron which is absorbed, and our body will use it. It is the elemental iron. Other is the salt. So as per recent recommendation, okay, now here I can explain it to you. Like the recent recommendation dose is 50 to 100 milligrams before and the maximum dose is 200 milligram. Before we have to use it 150 to 200 milligrams. That's why we used to give ferrous sulfate 325 milligrams 3 times a day, because it has about 65 milligram of elemental iron. So multiply by 3, it was 150, about 180. So we used to give this type of dose, but now we give 5. The recent recommendation tells us that we have to give the normal or a little reduced dose 5, because iron absorption, if you just give a lot of iron, but it will not be absorbed. Only 20 to 25% iron is absorbed. So why to give too much iron to a patient? Because that their patient will have GI irritation, dark color stools, and other problems with that. Okay, so 50 to 100 milligrams elemental iron per day is recommended based on updated hepcidin regulation absorption physiology. They have given a reason that when you give a lot of iron to the patient, initially the patient the iron will be absorbed, but then hepcidin will be released, because hepcidin is a negative regulator of iron. So hepcidin will be released, and hepcidin will not allow absorption of iron from the enterocytes, and all the iron will be wasted, and that causes other side effects of the iron. So better to give a single dose to the patient, and even on the alternate days patient will have a good response. Okay, so what is the preferred way of iron replacement for dialysis patient? Yes, for dialysis patient we give intravenous iron. Which of the following is used to determine CHR or reticulated hemoglobin concentration in an iron deficient patient? So but we use which it is used polymethenine is used for determination of reticulated hemoglobin. FITC and FICO erythrin is used in flow cytometry, and FLAIR is used for PNH. Okay, so which of the following can be used as an early marker of iron deficiency? Reticulated hemoglobin, CHR, ZPP. So all can be used as an early marker of iron deficiency anemia. Okay, reticulated hemoglobin is a reticulocyte hemoglobin content. It is measured on modern hematology analyzers by staining the reticulocytes, because reticulocytes have we have to stain the reticulocytes to know the to know the reticulocyte content of hemoglobin. Okay, so reticulated hemoglobin, the reticulocyte hemoglobin content is measured on modern hematology analyzers by staining the reticulocytes count with a fluorescent polymethenine dye. It binds residual RNA and then calculates their hemoglobin content. So what is the importance of that? It is an early sensitive marker of iron restricted erythropoiesis. Okay, so with the help of, if we see the reticulated hemoglobin is less than 29 or 28, it tells us directly about the ferritin levels of the iron stores. Okay, so if it is less than 28, we can say that the iron stores are deficient, and we can do the serum ferritin to confirm that. Next, you can see in the CBC, you can see these markers: IRF, HFR, MFR, and LFR. These are also and IRF. These are also, they tells about the other immature reticulocytes. Okay, they tells us about the bone marrow status. Okay, if IRF is increased, IRF includes HFR and MFR, high fluorescence reticulocytes, and medium fluorescence reticulocytes. Okay, so if they are increased, if IRF is increased, it tells about the that young reticulocytes are released from the bone marrow into the blood. It tells about the bone marrow recovery. It tells about the hyperproliferative state of the marrow, that bone marrow is working well. In case of hemolysis, also IRF is increased. Ineffective erythropoiesis, IRF is increased. But in case of aplastic anemia or bone marrow failure syndromes, we will see that IRF will be reduced. Okay, and LFR are the mature retics. They tells about if LFR is raised, it tells about the mature reticulocytes are present. Okay, and decreases with increased marrow activity. When the marrow activity is decreased, we have immature cells, more immature cells. Okay, so then IRF will be increased in that case. Okay, so it helps hematologists a lot, because we can decide on the basis of that our marrow is good in proliferation, or it is hyperproliferation is there because of any bone marrow failure or something. Okay, so what is the gold standard for diagnosis of IDA? So for the gold standard is for diagnosis of IDA, just go for a bone marrow biopsy and see the iron status by staining with the pearl stain. And so bone marrow iron staining is the gold standard. Okay, option C is correct here.